Welcome to this session. This is on the innovation stage. So we're here supporting people living with dementia and their caregivers in the community. So over to you. Would you like to introduce yourselves? Shane, would you like to go first?
Yes, absolutely. Hello, I'm Shainoor Khoja, founder of Thriving.ai, a physiotherapist and a tech entrepreneur. And I've had the privilege of working with Francis Duffy and Joan Condell from Ulster. I'll let them introduce themselves, and then I'll take you through some slides on the technical side of our project. And then Francis will talk to the results and the human side of why we designed the project the way we did. Francis,
Brilliant.
you want to introduce yourself before I start?
Yeah, hi, I'm Francis Duffy. I'm a consultant clinical psychologist, and I work in the Psychology of Older People service in the Northern Trust in Northern Ireland. And unfortunately, our colleague Joan Condell can't be with us today, but she would like to have been here.
Absolutely. Lovely. So this was a collaboration between Thriving.ai, which is a digital platform that basically brings who and what you need together on one platform to make caregiving easier and to allow the care recipient to have a voice in their care. And we collaborated with 60 Dementia and Francis, who is the clinical psychologist who could provide us with all the requirements that were needed by the patient and the family. And Joan and her team specialize in sensors and IoT and wearables. And so they were able to help us define what wearables and sensors we should use. And then we sort of digested the data. And from that, we got a set of results. As I said, I'm going to focus on the technology, and then Francis will focus on the human side of this. So as our system is at the moment, it's very fragmented and siloed, and people fall through the cracks, and therefore simple things become more complicated, resulting in unnecessary admissions and increased hospitalization, which increases the cost, but also increases burnout for the staff. And so we need a solution that is better prepared to support people at home with a preventative lens, because with the number of aging older adults and the increasing incidence of dementia, it is going to be impossible for our systems to be able to manage this cost. Globally, there'll be 2.1 billion people over the age of 65. In the UK, we're already 20% of the population, so that's 1 in 5 people. And additionally, 3/4 of the world does not have data on the aging population or aging in general, which is something that we're going to need for the next 30 years. Today, almost 50% of the National Health Social Care budget is spent on people over 65, with life expectancy increasing and 2.5 million people more living with major illnesses by 2040. This is an urgent problem that we need to get ahead of. So who are we helping? We have various stakeholders. We have Molly here, who is the care recipient, who can live in the community, can live independently, and is fearful of institutionalization. And she can live alone, provided with the right support. Ashley, her family caregiver at the bottom, is struggling managing kids, family, career, and marriage. And care coordination is a huge responsibility and worry. And 1 in 3 Ashleys leave the workforce, which impacts their future and their future care, as well as employers and tax revenue. Then we've got community workers, nurses, social workers, OTs, physios, etc. There's a huge shortage, a high level of burnout, and a lot of time wasted in administration, note-taking, etc. So anything that we can do to reduce this burden, make them more effective, is helpful to them and retains them in the workforce, gives them the time to do what they signed up to do, which is give care, not fill bits of paper. And then there are hospitals, home care delivery companies, social care, local authorities, etc., They have data, but that data is aged data. It's not real-time data or current data on which they can make decisions. Our platform allows them that opportunity to cut the data. When I talk to customers, they say to me, Shane, there's so many solutions. Where do I go? I don't know where I go. And this is why we talked to older people, we talked to caregivers and to the stakeholders, and they said they didn't want to go to 12 places. They wanted to be able to go to one place and get everything they wanted. And so that's what we built. So our platform here has within it a circle of care. This circle of care can communicate one-to-one, one-to-many. You can have mental health reporting in there that's self-administered. There's the ability for you to do a variety of socialization activities, which helps with loneliness and isolation. We have camera technology that can scan you for 60 seconds and provide you with cardiovascular indicators, respiratory indicators, and diabetes indicators. If you need, we can plug in sensors, which are smart plugs, bulbs, movement sensors, contact sensors, and wearables so that we can acquire the right data. We have passed all the regulatory landmarks to do this, and our platform is secure and encrypted. On the back end, you have various data dashboards. This is your data, you keep it, it's anonymized in transit so that it's protected, and you can cut the data and filter it in many different ways. When we tested this with the NHS, what we found is that this group of testers was 79 to 94 years old, and they had never used a piece of technology before. 90% of them could use it, and actually they hacked the circle of care to put 19 people in their circle of care so that they could video and have dinner together when they lived on different floors. 50% of family reported better connection and greater peace of mind and the ability to coordinate care on the go. And we saved 20 to 30 minutes for a caregiver or a visitor that was coming to visit the individual. And of course, we continue to build the data dashboard with care providers. For this particular project with Francis and Joan, we specifically identified dementia. And here we used IoT sensors and integrated wearables. And then Francis owns IP'd curriculum and interventions for dementia. And we created an activity board where the caregivers could log the activities that were done so that now we could monitor heart rate variability, movement around the property, pressure sensor, mobility, sleep, etc. And then because Francis worked with the caregiver, she could identify activities that the caregiver could instigate to mitigate any distress. And she will talk about this in detail. But basically, we got some early results that were very promising. We at Thriving are a multi-generational, multi-ethnic, gender-balanced team with all the right expertise. We've worked together, some of us, for over 22 years, and we're driven by profit and purpose. So we are all caregivers, and we have experienced this in our lives, and therefore we're driven to try and find a solution here. Francis, she's introduced herself, but, you know, she was a wonderful person to work with, and we continue to work with her. She has extreme knowledge and understanding from a physiological and a caregiving perspective in how to maintain people at home. And of course, Joan brings all the expertise and the power of Ulster University and their research team to help us bring credible results that are validated. Our ask going forward is that we're looking for care recipients and their caregivers that would want to join and try and test this. We're looking for home care delivery, NHS, health and social care champions, GP practices, geriatricians, neighborhood teams, social prescribers, any funders or charities that would help us scale our R&D in this area, because our initial results have been very encouraging and we would like to expand the pilot further. I'm going to stop here and let Francis take over. And I apologize that in a few minutes I will have to leave because of a competing session. But over to you, Francis.
Thanks, Shane. I'll just share my screen. Bear with me a wee second. Okay. Can I just check you can see the screen okay?
We can.
Great, okay. Thanks, Shane, and thanks for the invitation to present today. So I'm going to talk very much from a clinical perspective. So I'm a consultant clinical psychologist, and I work with older people services in the Northern Health and Social Care Trust. And I'm going to talk about Clear AI, which is our personalised activity recommendations. Sorry, I'm just going to move this from my screen because I can't see my slides. Okay. To reduce distress for people living with dementia using smartwatch data and AI modelling. And we were, why is this not moving?
Yeah, it is moving now.
It's moving now. Sorry, it wasn't moving there a second ago. So we were very proud that we were one of only 24 teams that were selected for round one of the prestigious Longitude Prize in Dementia. So that enabled us to complete this pilot study. So I suppose I've been working in dementia care for a number of years, and I support people who live with dementia who present with behaviours that carers find difficult to understand. And this is why this project has been really important for me and important for our service in the Northern Trust. So our team, initially, we got together a team which was Ulster University, the Northern Health and Social Care Trust, the Public Health Agency, Digital Health and Care Northern Ireland, and AGNI. And as a team, we then put in the application for the Longitude Prize. And when we were awarded the prize, then we really needed to work with companies who could help us with a little bit of the kind of the technology side. And so we went out to discuss with a number of different companies who provided information on what they could and couldn't offer. And then we collaborated then with Thriving.ai, sorry. As Shainoor said, dementia presents with a significant healthcare challenge, and the global prevalence of dementia is expected to triple by 2050. There's currently 55 million people living worldwide. In Northern Ireland here, 24,000 and 1 million across the UK. And these actually are probably very much an underestimate of numbers, because the data suggests that probably 1/3 of people with dementia don't ever even get a diagnosis. So the numbers are probably larger than this. So the project context then, 90% of people with dementia present with behaviours that carers find difficult to understand and manage. And these are often mislabeled as aggression, pacing, vocalising, exit seeking, and sexually inappropriate behaviour. And I'm going to give you an example for context. If you imagine you were lying in bed this morning and two strangers come into your room and started to remove your clothing, you'd be terrified. But this is the experience of hundreds of thousands of people living with dementia every day. But when they respond in a way to defend themselves against what they believe is assault, then what happens is that their behaviour is labelled as aggressive, whenever the person's actually really just frightened. So there's a significant misunderstanding of dementia, within the community, for caregivers, and also for health and social care staff. Sorry, I don't know why this is playing up on me here. Sorry about this. And what happens is when these behaviours present because of misunderstanding and fear, the person then experiences, distress. As they're trying to meet their needs, as in this particular example, why are you in my home? You're frightening me. And these changes in behaviour and this response in terms of fear and distress causes significant stress for the carer. And it also presents a risk that the person will move from their home into a care home. Because what can happen is if the person declines to support with personal care and the care staff, and they need support with personal care, this can lead to a breakdown in the placement at home, and the person may need to then move to a care home. Or it may well mean that they have an unnecessary admission to hospital. Or for the person, they may be prescribed psychotropic medications. And these psychotropic medications have got significant side effects that include increased risk of death and stroke. So, but in order for us to really kind of fully understand the person with dementia, what we need to know is we need to understand their life history, because sometimes care staff go in to offer support with someone with dementia, but they don't really know anything about them. So we need to provide caregivers and the staff that are going in to offer support with information about that person's life history. We also need to understand the person's daily routine. How do they spend their day? What do they have a routine, or is it fixed routine, or is it kind of quite chaotic in some ways? Because sometimes we all enjoy our routines, but sometimes when someone's diagnosed with dementia, the routines can significantly change, and sometimes the routine isn't the same, and we all thrive and feel secure within routines. But what we also want to know is what activities cause a person distress in their day? Because at some point throughout the day, most people with dementia will experience distress as they're trying to navigate their world. But what we also want to know is what activities does the person engage with that actually reduce their distress? Because if we can understand this, then we can actually avoid those things that increase distress, and we can encourage more things that actually reduce distress. But this is really hard to I'm sorry about this. There's something happening with my computer here. We actually rely on carers to provide us with much of this information about the person's day, but it can be really difficult to get accurate information about what's happening in the home and when the person experiences distress. And a lot of this is because a lot of the carers actually are older people themselves. And when you're caught up in a situation where the person's experiencing distress, it's very difficult for the person then to kind of keep diaries for us. And like all of us, our memories, irrespective of what age you are or whether you have a dementia or not, none of our memories are particularly accurate when we're trying to record information that happened, days or, even weeks ago. So it's hard to get this information. So we had very much had a collaborative design process in trying to understand this a bit better. So what we wanted to do was we wanted to develop a system for monitoring and analysing early signs of distress in the person living with dementia and also their carer. And we wanted to then have data-driven recommendations on interventions and then use machine learning prediction models. And the reason why we wanted to understand distress in the carer as well is because if the carer is experiencing distress, there's a good chance that the person with dementia will also experience distress. And if the person with dementia experiences distress, the carers are likely to experience distress as well. So we wanted to see, how these things interact and interact with each other. But the aim of this project was really to reduce the likelihood that the person at home was going to have to go into a care home, or at least delay that admission to care home for as long as possible. Because people with dementia want to stay at home as long as they can. And their carers want them to stay at home. So husbands and wives, family want the people to stay at home as well. So that's what the aim of the project was. And we actively involve people living with dementia, their caregivers, and the public in our pilot design. So what we did was we had a wearable smartwatch that monitored heart rate changes throughout the day, and that also monitored sleep quality. We had developed a user-friendly mobile app. This was an electronic log of activities and the interventions. And then we also had room sensors to monitor location. And we have data also, we use like sensor mats as well, but I'm not going to talk about any of that just today. So this is the smartwatch. So basically, we offer the smartwatch to people living with dementia and also to their carers. We find that the people living with dementia actually really enjoyed wearing the watch, and they actually like to interact with the watch, because one of our concerns was would people tolerate the watch? And we find actually that we didn't have any issue. There wasn't anybody that we offered the watch to that declined to wear it. And sometimes the watch was almost seen as an activity for the person with dementia. And then we had these are our room sensors. So these sensors were just, placed at a location within all of the rooms in the house. And so we weren't taking any, video footage or anything. It was literally monitoring movement. And then what we could tag is using the watch, we could tag the person that was actually moving from room to room. And this was also really important for us because we wanted to see is, does distress increase when the person's on their own? Does it increase when there's certain people with the person? And how does that kind of change throughout the day? Or what we also wanted to know is, how long the person with dementia spends in particular rooms, because like any of us, we can't spend the whole day in the one location. If I'm sitting, in my living room for a period of time, after a while, I'm going to want to get up and kind of move around a wee bit, stretch my legs, and change location. So this was our mock-up to make sure that all of our sensors work. So we used this at Ulster University Lab. So we had a mock-up kind of, bedroom, kitchen, etc. And we were able to monitor then, do these location sensors detect where the person is. So in this case, you can see that our researcher is in the bedroom. And then when the researcher moves to the kitchen, we need to check whether or not that the sensors were tracking, kind of what that movement was. And we got that working, then we were kind of good to go. This is our activity log, and I'm not sure how clear this is in terms of you can see it. So what we did was we asked the caregivers to give us examples of all of the activities that happen during the day. And we'd include things like when friends and family visit, care visits, when the person's eating, maybe when they're watching TV, or any activities that that person particularly, engaged in or enjoyed throughout the day. And we would have put that list into a mobile app that was developed by Thriving. And then all the person had to do was to select the activity and then record the time when the activity started and the time when the activity ended. We got lots of feedback from our caregivers throughout this process, because what we wanted to do is we wanted to really adapt the recording as we moved on. So based on feedback from our caregivers, we made some changes to this. And one of the first changes we made was to be able to enter some notes, because what we found was that if there was multiple caregivers and multiple family members, what they wanted to do is sometimes to be able to share information within the app, with their other family members. And this was particularly important if the family wanted to actually detail that the person with dementia had taken their medication or hadn't taken their medication, and they were able to pass that on to carers and caregivers. But we've got some additional feedback from caregivers, and we actually will make further changes to this app at the next stage of the project. So this is the data that we collect, and this is kind of, I suppose, the interesting bit for us. So what we have here is along the bottom of the graph, we've got the timeline, and in the green graph here is the changes in heart rate for that person, across the day. So we can see then, and then the activities that the caregiver records. So we can see here when the person's eating, when care staff visit, when they're watching TV, eating again, and when care staff visit. And what we can do then is we can look and we can see what are the times in the day when there's peak distress for the person with dementia. And we can see here that there's a significant change in heart rate here when the care staff visit. But what we need to do is we need to delve into this a bit deeper. Is that change in heart rate because the person's moving around a lot when they're being supported, for example, with personal care? Or is it because they're actually feeling quite stressed? And we can compare this with another care visit, and we can look to see, and we can see that the heart rate is much less. And again, that might be because the person had a much more sedentary position, or it might be because they actually interacted better with that caregiver and had less distress. So as we build up time and we get to understand these patterns, we'll be able to predict better exactly what's causing those changes in heart rate. And another example of this, this was something that came out, which we weren't actually expecting. And what we'd asked the carers to do was to start recording for anybody, in particular if they were prescribed a psychotropic medication, to record when that psychotropic was administered. And what you can see here is that this particular person was prescribed lorazepam. But whenever you look at the data, you can see they actually weren't distressed whenever that lorazepam was prescribed. And we can see here again, whenever they were prescribed quetiapine, there hadn't been an increase in heart rate. And the same thing again with lorazepam. So these psychotropic medications were prescribed PRN for the person. But when we were able to show this data to the carer and say, actually, help us to understand, why this medication was administered. And we're actually able to show them the medication wasn't really having an impact on the person. That was really a game changer for the carer for this person with dementia. So by being able to share this data in a usable way, we were able to open up conversations with caregivers and the caregiver offered support in a different way. So what our intervention was once we understood what the pattern of the person was during the day, what we started to do was we introduced a variety of different activities for the person. We were able to create a daily routine for the person. We were able to monitor their stress levels, and then we were able to identify which activities the person really engaged well with and reduce their distress, and other activities throughout the day that they didn't engage well with and actually potentially increase their distress. We shared all of this data with the caregiver so that they could then make changes to routine as necessary by swapping in and out activities throughout the day. So the outcomes of this then were, first of all, there was reduced stress for the person with dementia and their carer, which was great. The carer also felt much more empowered because it's difficult to know exactly what the experience of the person with dementia is every day, particularly if they can't verbalize how they're feeling. So using this heart rate monitor, it was almost like providing us with a window into the experience of the person with dementia. And the caregivers really, they really benefited from understanding this. And it also was reassuring for them as well, because it helped them to understand that actually the person that they were supporting wasn't distressed throughout the day. And they were able to then to see small interventions that they had that could have a really positive impact. So this improved the quality of life for both the person with dementia and their carers, and it actually improved their relationship. It also enabled the person to remain at home with increased independence. Everybody who we offered this service to was at risk that they were going to have to move into a care home or a potential admission to hospital, because the caregiver was experiencing significant carer stress and burnout at that stage. But really significantly for us was we discovered that for 2 of the people on the study, that they were prescribed PRN psychotropic medication, and they actually discontinued using this medication, which had significant benefits for the person. They were much more alert throughout the day. Their mobility had actually increased, and they were just engaging more with the carer. So just for, also we have, it was funded by Health and Social Care Board Northern Ireland. We have a free Clear Dementia Care app. So if any of you are supporting for or caring anyone living with dementia, then please feel free to download this app, from the App Store or Google Play. It's free. You're not going to get any ads or anything with it. And we find that our caregivers and our care home staff and our home care workers will use this app frequently to get information about dementia. So the next steps for us really is that the pilot study was completed in May 2024, and that showed us the feasibility of streaming this granular physiological data to a centralized cloud from the service user's home. The plan for our final solution would require initial data collection period for 7 days per user to establish a baseline of their personalized normal heart rate. And that goes back to the point I was making, where when heart rate increases, some of it's due to movement and some of it's due to stress. So this helps us to tease out that data if we've got a 7-day data collection period. And then after this period, we can stream live data through the IQR model to detect periods of distress in real time. And that's really important that it's in real time, because it helps us to see, what's happening in the moment. And then recommendations for appropriate personalized interventions could be supplied through the app to the caregivers. So we plan to analyse them. We haven't finished that at this stage. We plan to analyse the next stage is to look at the location data, to look at proximity to caregiver or periods of loneliness as and when the person's on their own, and how this affects their distress levels. And then this data will be incorporated into our recommendation engine. So that was a real whistle-stop tour through our project and the data collected. So if we've time, I'd be very happy to answer any questions.
Thank you so much. That was absolutely amazing. Very insightful, Frances, and thank you to Shane as well. I would like to open it up to the floor. Has anybody got any questions to pose to Frances? You can either put it in the chat or please do, just come online and we can talk through it. I mean, I do have a question, and I don't know whether because you did say that the app was actually being developed and tweaks were going to be made. But I just think it's absolutely essential that people know the person you know, and build that picture of who that person is, because that will give them the sort of triggers that perhaps, you know, from a positive outlook and from a negative outlook, that the activities that that person could do. But I know that you're tracking the activities, and I was just thinking that, is it something that when you could record the interaction, was it a positive or negative interaction, just like with a smiley face or a sad face for the caregiver? I don't
Yes,
know.
that's a really good point, Sue. So as I say, we've engaged a lot with you know, with our caregivers to look at that. So we've a number of recommendations of what they've suggested. And that would be, and what's also really interesting, that's why I really like your point, is because not only will we have the smiley face or the kind of the cross face or whatever face you might have, but then we can map that on with the actual physiological data. And we can see, is the caregiver actually quite good at actually interpreting what the reaction is of the person with dementia. But it was, I suppose, like I just really loved this project, I have to say, because like I work with people who are living in care homes, and I work with people who are living at home. And it's kind of heartbreaking when you see the distress that people with dementia experience. And it's not that the caregivers want to do anything wrong. Like every member of staff or every caregiver that I've ever worked with always wants to do the right thing. That's what they want to do. But sometimes, without realizing, we do things that actually increase someone's distress, and we're not doing it on purpose. But the problem is we don't know that we're doing it because we're not intending to do it. So what this enabled us to do was really to get that really accurate data in terms of what the experience was, and then monitor kind of the impact of that. And when I'm talking about interventions, I'm not talking about anything like rocket science or anything. I'm talking about, you know, as you said, the life story is really important. So when you know what someone likes to do, then you can offer them activities that that they enjoy. So, for example, one of the ladies, I don't know if you use this expression, but her daughter described her as like a footerer. I don't know if you know, she likes to kind of footer about with things. Like, so what she just likes to kind of like, you know, touch things and kind of, you know, she'll rummage through a bag and things like that. And she said, my mum was always like a footerer. So what we did was we just created a rummage bag for her with things that she liked. So she loved jewelry. So we put a load of jewelry in it. We put all the kind of things that she liked. And this lady was able to just, you know, take the jewelry out. You know, she would actually take it and move it around the house a lot, and then the daughter would have to find it and put it back. But she was occupied and really loved doing that for a long time. And then we had things like, you know, sorting socks. And I was saying to the daughter, you know, like, would she sort pairs of socks for you? Because we all need really, you know, like occupation is so important to us, like, and it's important to people with dementia. So I knew that this was something that my mother used to always do for me. She would pair up all my, you know, kind of odd socks. So I said, would your mum do this? Her mother loved pairing socks to the point where this lady experienced significant distress being supported with personal care. She would not accept anybody supporting with personal care, and that was presenting a significant risk to her. So I said, could you put a basket of socks in the bathroom? So she put a basket of socks on a stool in the bathroom, and this lady sorted these socks while she was being supported with personal care. So her attention was distracted from the support, and she was just sorting away at these socks, which she really enjoyed. So all of the thing about these interventions, they have to be something that fits into someone's day. They have to be realistic, and they have to be easy to access. And also the person has to enjoy them. So these are the types of interventions that we had, and then we could monitor the impact. Now, not everybody's going to want to sort socks, you know, but this particular lady did. But we find for our, you know, for other people, males and females, they like different things. But what we just tried to do was try and find a range of things that they enjoyed. And it was trial and error. You could try something, it might not work. You would try something else. And also, as we know that for all of us, our interests change, you know, all the time. And for someone with dementia, it may well have been the same thing. Their interests can change. And sometimes as their dementia progresses, their interest changes as well. So it wasn't just saying, oh, you know, the person loved to do this before. It may well be that those activities weren't things that they enjoyed any longer. So there was kind of quite a lot of creativity involved in it, and a lot of kind of partnership working with the caregivers to find routines and activities that the person enjoyed.
And it's such an important part of, because as you say, the people with dementia is growing significantly, and we need to find a way of really supporting them to thrive in any way, shape or form we can. Yeah, absolutely. Has anybody got any questions? Mark?
Hi, Sue. Thank you. Thanks, Francis. I'm coming at this from two angles, really. One from up until last year, I used to do contracting for social care within Torbay. And also I had my father and my father-in-law both had dementia before they passed away. So I've got two angles to come from there. My first one is from the care side. Sorry, from a patient side and a relative side. And that is when my father was at home, he had so many different carers. They changed on a daily basis. He'd have, 10, 15 minutes care in the morning and then in the afternoon. So it's really difficult for them to understand my dad. They met him once, maybe a couple of times, and that'd be it. So I'm not sure how the app, well, I can see how it could help them, but that continuity, I think, would be really, really challenging with that changeover of caregivers. When he went into the care home, and my father-in-law similarly, it's a different story. I can see that working really, really well there. Or indeed, when there's a continuity of a relative caring at home, I can see that working well. I don't know if you want to come in on that before I go to my other point, but that it was just that break of service, I think, might be challenging.
Yeah, Mark, I'm so delighted you asked me that question because it's so important. So you're right. When someone's living at home, there can be a multitude of caregivers that come in, for them. And we all have different approaches. So the way that I approach someone is going to be different than the way that you approach them. And you could have maybe 20 people approaching you in a different way. So what this enables us to do, the first thing we do is we look at the care staff that the person responds well to. And then we understand what their approach is. And then we share that approach with all of the other staff. And we look at the approaches that don't work so well, and we talk to staff about avoiding those approaches. But what we do is, I've only given you a brief snapshot of this, and I'd be very happy to talk to you more about it kind of offline if you want it. But we provide written recommendations for all of the care staff down to, so it's not just a care plan in terms of going and support with personal care. It's, this is the way you approach the person. This is how they like to be offered support. And we give them very detailed advice about how to offer that support. And it's based on learning what works for the person. Because usually, and if you've got 20 care staff, there'll be at least one who finds a way of interacting with you, because even just the way they speak to you, it might, some people might go in and say, "Oh, hello, love, how are you this morning?" And some people might hate that. They might hate being called love, or some people might have a kind of a name that they like to be called by. Even things like bathroom. Some people use the bathroom, some people say toilet, and some people say loo. So all of that minutiae of detail that's really important to the person, we find that out and then we share it with all of the caregivers. I hope does that answer your question?
Yeah, it does. I don't want to challenge that, but that sounds great with that continuity. But if you've got different carers coming on shift, going off shift, different days, I suppose my experience is probably tainted in some respects because my father-in-law was a very he ticked every box that was mentioned earlier about the behaviors that are demonstrated by somebody with dementia. And many of the people where he was being cared for were in a similar position. So there was some violence, all sorts of things. So I've probably just seen a very narrow focus of that care.
No, you haven't, Mark. This is universal. It's across the piece at home and in care homes, and it comes down to staff training. So another thing of what we do is we do staff training. We do extensive staff training because if the staff don't understand dementia, they don't understand the perspective of the person with dementia, and their care is different. If you understand dementia and the perspective of the person, whenever you have empathy, your care changes. So I can well believe that you have seen very negative experiences across the piece, because there are, and it comes down to staff training.
Sorry, I didn't mean that. I wasn't focusing in on the capabilities and the care of the providers. All of that was fantastic, and I had the situation where actually I had been involved in contracting for the service at one of those homes in my work job, and as I was a recipient as well, and the care they gave was phenomenal. So I didn't mean it negatively, but it is, I suppose it is a negative. It is something to learn from.
Yep.
Yeah. Sorry, can I just
yes,
make,
did you
sorry,
ask
Sue.
another question? Did you, I know we've got till 10 past, so.
That's all right. Thank you. I didn't want to overstay my welcome. My other question is, as a contractor, going back, putting my hat on when I was doing that, one of the things that became apparent in Torbay, they did a lot of work looking at domiciliary care providers. And I'm just thinking one of the things for was it Sean? The earlier notes about some of the key points. Sorry, I'm rambling a little bit there. One of the things they identified, that domiciliary care workers in a normal year in Torbay covered 1 million miles travel. So there are some carbon issues there potentially, and some benefits for saving. But also, if you think about that care, those care providers couldn't provide any care while they're driving around Torbay doing 1 million miles a year. That is staggering. And I think that might be one of the things that you need, that would benefit you by putting on your benefits, because if you could reduce the care or reduce the need for care traveling around, obviously that's going to have a significant impact. Thanks both.
Thank you.
Thanks.
Well, that was absolutely amazing. Thank you very much. It is definitely an area and one to watch there. So I really do wish you all the very best. And I'm sure we will be speaking to you again soon, because that was absolutely fabulous.
Thanks.
So thank you. Thank you so much to Francis. Thank you to Shane. And we look forward to seeing you all soon.